For those of you who don't know me, I'm Jay Kumar. I'm one of the fellows this 6 months, and I am very excited about this one. As the title says, this is a Christmas carol, spines of the past, present, and future, with a pretty big
Nice.
emphasis on the past. But in the nature of the holidays, we're going to take a tour of the things that brought us through today. So as is tradition, here's our overview. We're going to be taking a trip through early history, classical antiquity, all the way through the modern era, and then looking at innovation and research going on today. And then we'll hear from an amateur's comments on the future of spine. So first, why is Jay boring us with the talk on history? Well, as this quote has been paraphrased and repeated so many times throughout our history about the value of understanding where we come from. And it really speaks to me. I think it means it's very pertinent, especially in today's era where things are getting so numerous and a little bit confusing to try to put your hands around everything that's coming and going, what's a fad, what's going to stay. And so I think it's helpful to look backwards to see where we've come from, and that can help inform where we are today and where we're going. And standing on the shoulders of giant springs perspective, and it's just plain fun. All right, let's get to the meat of it. So we're going to start with spines of the past. And we'll start, well, really even before classical antiquity, which is traditionally defined in Europe as about 3 to 500 BC through 500 AD. We're going to start even further back in the country of India with Lord Krishna, who is a classical major Hindu deity, god of compassion and love, reincarnation of another deity named Vishnu, central figure of one of our ancient texts called the Mahabharata, and often seen playing his flute, as you can see here. But more importantly, in terms of what we're focused on today, as far as I can tell, this is one of the earliest, if not the earliest, first documented instances of someone doing something for the spine. So in the Srimad Bhagavatam Mahapuranam, which is a collection of Hindu epic myths, Lord Krishna corrects the hunchback of one of his followers, Kubja, who is an obvious gibbous here, with axial traction. He steps on her feet and he pulls her up by the chin. Only a god can do that, but it was cool to see that some of these concepts have been around for quite some time. Our next stop takes us a little bit west to the country of Egypt with the interestingly named Edwin Smith Papyrus. This, as far as we can tell, is the oldest known surgical text. It focuses on traumatic injuries. It's a 15-foot scroll, and though this dates to approximately 1550 BC, all of these dates are ballparks, just so we don't get bogged down. It's probably a copy of an actual older text, just by the time they actually got down to writing it down and taking it out of the oral tradition. The authorship is unknown and sometimes attributed to this guy named Imhotep. Now, Imhotep was a man, an interesting person in Egyptian history who actually developed the first step pyramid. And in the 1 to 2,000 years after his passing, he was elevated to the status of being a god of medicine, but he was just a dude like anybody else who was a famous architect. And he actually, that famous movie with Brendan Fraser called The Mummy, the villain is named after him. It's now it's now named for an American antiquities dealer who just happened to buy it in 1860 as is tradition, named Edwin Smith. But in regards to the spine, it documents 48 cases of trauma, and 6 of them were spinal. 5 cervical injuries, 1 lumbar, and based on what they describe in terms of bowel bladder function and motor sensory losses, we can ascertain that 2 of them were actually spinal cord injuries. As far as we can tell, this represents the earliest known description of signs and symptoms of spinal column and spinal cord injuries. And these are 3 index cases that I just pulled out to show what they were kind of looking at. Here we've got genitourinary function, and here we've got already some understanding of the intuitive notion that if the vertebrae are not where they're supposed to be, badness is to follow.
I know where.
And this is a slide from my last talk where we took a trip through the history of thoracolumbar trauma, and I said the journey to 3 columns, and we started in the 1900s. So it actually does, of course, start a little bit sooner than that. This is back in ancient Egypt. Back at that Edwin Smith Papyrus. It's the first instance of the idea of a spinal column. I apologize to any Egyptologists on the call, but I think it's pronounced jet or jed or something along those lines. This was the first description of a column. And it was so important in Egyptian history that it actually became the symbol for Osiris, one of the key deities. And this knowledge came from their embalmers, the people making the mummies. We're done with India, we're done with Egypt. Let's get to true classical antiquity with ancient Greece. So this guy needs no introduction to anyone in this room or on this call, but he is so called the father of medicine. We all know the Hippocratic Oath, but the thing that he did that was so clever was that he applied scientific thought and close observation and logical reasoning to medicine, which at the time, for most of humanity, was a supernatural phenomenon, and he came at it with a more logical perspective. And you'll see that becomes a trend as we take this trip in terms of what are the things that allow us to make forward progress. And interestingly enough, even this OG said one should first get a knowledge of the structure of the spine, but this is also requisite for many diseases. So the spine is front and foremost from the very beginning. He classified the vertebra roughly into the same three groups that we use today. He did not give us those names, but he did classify them into those groups. And he even classified spine diseases. He had kyphosis, he had scoliosis. All scoliosis was scoliosis to him. It was not further defined yet. He described concussion, which we would now describe as a burst fracture, dislocations, and spinous process fractures, which even he thought were did not require a consult to spine surgery. He gave us at least three particular innovations. This is one of the more famous, the Hippocratic ladder. This was wild. Basically, he tied people up either by their head or by their feet, and then he shook them to try to get the curvature to go away. If the hump was in the cervicothoracic region, he hung them up by the head. If it was lower down, he'd string you up by your feet, and then apply succussion or shaking while tied to the ladder to try to get the deformity to correct. He also gave us the Hippocratic board and bench, which is used in a lot of different areas, but with regards to spine, it was a way to apply both spinal traction and simultaneously apply focal pressure to one area. You could use your hands, your feet, you could stand on them like a Thai massage, or even use a plank to exert more diffuse and even pressure. And then the Hippocratic scamnum, which was, quote, the most powerful of the mechanical means that he devised. This is similar to the plank on the bench, but basically you just put the patient on the ground, cut a hole in a wall that made sense, stick a board in it, and press down on it to try to correct that. Of note, in some of the instances, they find that when you do these, surprise, surprise, they start having difficulty moving their arms and legs. So it kind of went away from these things as time moved forward. A brief note on Aristotle. He didn't do much on the spine as far as I can tell, but he did observe the muscular action of animals, and he looked at and he thought about how the muscles interacted with the joints, how the vectors were applied to create different types of movements, and he considered the role of the animal center of gravity. And while he wasn't doing as much of this in humans, these early studies were useful to some of the future characters in our story. All right, we've crossed BC into Common Era, and we start with Galen of Pergamon. This was another Greek physician, surgeon, philosopher, but he was living in ancient Rome. He was physician to my favorite emperor, Marcus Aurelius, as well as his descendants Commodus and then Septimius Severus. And he really defined anatomy and physiology for a millennium. For any neurosurgeons on the call, you'll all be familiar with the vein of Galen, but he was also known as the surgeon of the gladiators, hence Russell Crowe's image here. And he's gone on to become known as the father of sports medicine for giving his role in really writing the text that for the next 1,000 years would define how humanity thought about anatomy, how humanity thought about physiology, until some people had the courage to do further studies and confirm or refute some of his ideas. In regards to the spine, he confirmed and improved upon the works of Hippocrates and Imhotep, and he gave us the words kyphosis, lordosis, and scoliosis. Here you can be seen using some adaptations of Hippocrates' bench and scamnum and Moving a little bit further ahead, we get Oribasius. He was another Roman emperor's physician, and he just added this third bar in the middle to the Hippocratic board and bench for more focal and more control and manipulation. We get next to Paulus of Aegina. This was another Greek physician, but this, of course, now we're moving past 500 AD, so we're getting into the Byzantine era. And this is the last stop in our trip of classical antiquity. There's a lot of fathers in this story. Everyone needs a title, just like today. This guy gets father of early medical writing, but he did do some clever things. Antisepsis theory was, hundreds of years away, but he was washing his wounds with wine. We see this a little bit in Persia as well in the years to come. And he is credited for doing the first attempted laminectomy. We don't know how the patient did, but supposedly Paulus was satisfied with the results. So we can trace that surgery back 1,500 years now. All right, then we get the Middle Ages in Europe, where things slow to a halt, and spine takes a backseat to other political concerns going on. But across the way over in the Middle East, we have Avicenna, who's keeping the thread alive, and his text would be translated into European languages to kind of keep the chain of knowledge continuous. So he was a physician in Persia, in what is now modern day Uzbekistan, and he wrote a canon of medicine, kind of consolidating Hippocrates, Galen, and some other thinkers across the centuries. But his book included 8 chapters dedicated to the spine that have actually been translated and you can read. And I'm not going to admit whether or not I read them, but they were actually quite fun and surprisingly not that droll. He described human biomechanics. He gave us the ideas of flexion and extension. He gave us lateral bending. He gave us axial rotation. And giant caveat that I should have said at the beginning, these are who these things are ascribed to, but obviously the truth of who came up with these ideas is probably a little bit more mixed. He also gave us functional spinal anatomy, and he noted that different vertebrae looked different, and perhaps that had to do with their function, as we all know about facet orientation today. So that thought goes back quite a while as well. Next, we get al-Zahrawi, who was in the Iberian Peninsula, a Muslim in Spain, court physician to the Caliph, living in the golden age of Arab Spain. And he is credited with actually doing the first thyroidectomy. He's kind of a big figure in that world. But within the spine, he actually stressed the prognostic importance of incontinence and motor sensory deficits in spinal cord injuries. So he noticed that there were spine injuries, but also cord injuries, and he thought that if they had bad deficits before, they were likely to have bad deficits in the future, and those were likely irreversible, a key insight. Cauterization was also kind of the craze at the time, probably because it killed bacteria, but people were using it on ulcers, and because it seemed to work for some things, anytime something works for something, you try to apply it to everything. So he has some passages where he describes applying cauterization to the spinous process, but cautions that it should only be done by someone who really knows their anatomy. Not sure about the results of the therapy, but it's an interesting side note on our pass through history. All right, we've moved out of the Middle Ages, meanwhile, in Europe, and we've come to the Renaissance. And it's impossible to talk about the Renaissance without talking about the guy who epitomized the time, our artist, scientist, and inventor, Leonardo da Vinci. And quick side point, if anyone ever finds himself in Florence, there's all the cool things in the books, the Il Duomo and the cathedrals, etc. But I implore anybody who goes to look up this tiny little off the beaten path museum where they have taken all of his drawings and recreated them out of wood. So he's got a hang glider, he's got a printing press, he's got like a little card type thing. And it was really sobering to see how much I've aged in the years since I've been there. Now I look as decrepit as the guy on the left. But we do share a birthday, so there is that.
And the beard.
And the beard.
Your beard's headed that way.
There are a few white hairs. I have to pluck them every now and then. In any case, he considered the importance of the muscles for the stability of the spine. Now, these drawings were not made popular. I'm not trying to give Da Vinci a whole ton of credit where it's not due, but these drawings do exist, and they do obviously demonstrate his thoughts on how the muscles are involved and how they attach and how they are meant to hold the head up over the chest. This becomes relevant later when we get into biomechanics. Our next gentleman is Vesalius. Today, he is considered the father of modern human anatomy with his seminal text De Humani Corporis Fabrica, where he, interestingly enough, he drew human bodies in motion and then stripped the skin off. That was kind of one of the key interesting things about his contributions to anatomy. But the big thing he did is that after our boy Galen back in 1200 AD, there was 1,000 years of people basically saying, okay, Galen is gospel. The way you study anatomy is by reading the old texts. Don't touch the body, that's sacrosanct. And Vesalius kind of did away with that tradition and got in there with his own hands, did his own dissections, and confirmed some of Galen's theories and rejected others. And it gave birth, in the tradition of the Renaissance, to a new sense of Enlightenment style thinking and doing anatomic study through dissection. And I think we would get along because, as we all know today, surgery is not a spectator sport, and this tradition is alive and well in all the residents and fellows who are still going to cadaver labs today. He described the intervertebral discs and the neural frame, and he confirmed the flexion extension mechanisms of Avicenna from Persia. But he needed to study his history a little bit more because he's clearly not imbibed the idea of the normal lordotic, kyphotic, and lordotic curves of the spine in every region. This person needs some serious work. This is our last stop in the Renaissance before we get to the early modern era. Giovanni Borelli was a student of Galileo and a professor of mathematics at the University of Pisa, I believe. His big thing was he took his mentor's analytical methods that he was using to study the heaven and give us the concepts of gravity, applied that mechanical understanding to biology. And he birthed a new area called iatromechanics. And this would lay the foundation and become the forefather of modern day biomechanics. So this guy gets the title father of biomechanics. And he gave us some very interesting things. So he did calculations and he found that the weight that the spine would have to bear was greater than the strength of the muscles to hold. So whereas Da Vinci gave us, and people before Da Vinci gave us the idea that the muscles had to hold the spine up, he was the one who said that, the muscles can't do it alone. So he actually postulated that the disc might be viscoelastic and that it must also be load bearing. And he put the disc in the focus, which was a new concept at the time. He was also the first to study the human center of gravity at the time, called the human weight center. So this is kind of connecting that thread back to Aristotle, who did it in animals. He's bringing it into humans. And of course, this would be the early work that led to our now famous Dulce's cone of economy that we all know and love. All right, I'm done taking you through drawings of people. I'm now going to take you through black and white photographs of people. And it's hard. I don't think any talk that discusses the history of spine is complete without this photo of the founding of SRS with our Dr. Arbarnia's mentor, John Moe, front and center, of course. But we're going to take a trip a little bit before this picture and start with H.J. Klein, who does the first laminectomy in the early modern era. This was a British surgeon in London. He attempted a multi-level laminectomy for a thoracic fracture dislocation. And this kind of started a dark run in spine surgery. In his early days, he did not reduce, and the patient unfortunately passed away 3 days later. And this, along with multiple other mortalities at the time in the early 1800s, darkened the medical community's attitude towards spine surgery, and it was seen as a thing that should not be done. About 15 years later, a gentleman named Alban Smith, who's again, just like H.J. Klein was little known, so was Dr. Smith, a surgeon from Danville, Kentucky. But he actually documented a successful laminectomy. The patient had traumatic paraplegia after falling from a horse, something we still see for sure, and the patient survived with at least partial neurologic recovery. But it is important to say, as a background to this, we're in 1828 right now. The day pain dies, the day anesthesia becomes a big deal isn't until the 1840s. So we're living in a pre-anesthesia world where antisepsis is still, very primitive in its time. And I think we can give some of these early surgeons credit for operating under such conditions. Over the next few decades, laminectomy evolves. There's this one technique called an osteoplastic technique where they can H-like incisions. So two paraspinal incisions, as if you're doing a Wiltshire approach, connect them with a transverse incision. And then you elevate flaps of skin, muscle, fascia, and bone to decompress and then put it all back together. I'm not sure why it didn't catch on. Hemilaminectomy was also invented about 100 years after Klein, simultaneously by two people, a guy named Taylor in New York and another person whose name I could not find in Italy around the same time, where they did much that we do today, midline incision, subperiosteal dissection, and Doyen saw we don't use that as much anymore to remove the hemilamina. And just like detractors of MIS surgery today, back then they said, I can't see anything, and how do you know you're doing enough decompression? So those critiques have been around for a minute. Hopping back a few years, we also see the first laminectomy for tumor. Victor Horsley, one of the founders of Fathers of Neurosurgery, was a London neurosurgeon, and he was Sir Victor Horsley, a knight. And He performed the first successful case of a laminectomy for an extramedullary tumor. This is a really cool story. I won't get into all of it, but there was a neurologist in London, one of his colleagues, and he diagnosed a patient to have a extramedullary tumor causing pressure on the spinal cord purely through the physical exam in the late 1800s, no imaging. It was amazing. And he referred him to Victor Horsley, and 2 hours from consult, the skin incision was made. And there's some mutterings about how they had to do a little bit of work with localization based on the neurologist exam, Dr. Goers. But they found it. The patient was an Army officer with back pain, urinary retention, paraplegia, and thoracic sensory level. And the tumor was successfully resected and called a fibromyxoma of the theca. I wonder what that could have been. And after this meningioma was removed, the patient had a full recovery and no recurrence and died of unrelated causes 20 years later. A seminal moment in our history. Over the next 80 years, then, we get the saga of the discectomy. So after Borelli gives us this idea that the disc might be viscoelastic and it might be load-bearing, it might be very important, we can try to consider, okay, what is the deal? What clinical relevance does it have? So over about 40 years, from 1850s to 1890s, we have a number of people, including a key couple whose names we might recognize, doing autopsies on people who passed away from traumatic injuries and noting at the time were considered incidental traumatic disc ruptures. Rudolf Virchow's triad was a German physician of another father, this one of modern pathology, did an autopsy, made this a note. And then Emil Kocher, a Swiss surgeon who won the 1909 Nobel for thyroid surgery, and of course we use his instruments today, noted this on autopsies 50 years later as well. A couple decades after that, a gentleman named Joel Gottwait, who was the chief of ortho at Massachusetts General Hospital, connected disc fragment with back pain. A few years after that, Walter Dandy, a well-known American neurosurgeon, connected disc fragments with cauda equina. But it wasn't until Mixter and Barr, neurosurgeon ortho working together, where they did the first successful discectomy. And Barr, interestingly enough, had done some pathology work with this man named Christian Schmorl, who of course gave us the Schmorl's note. And so when they took out what they thought was a tumor or chondroma, what they had originally described it as, he recognized fibers as being actually, oh, this is disc, that's what this is. And so they recognized what they had on their hands, and the idea of a discectomy started to catch on. And then a few decades later, Yasser Gil, who's a well-known microsurgeon and neurosurgeon, does a lot of aneurysm work and is still alive today, the tender age of 97, applied the microscope for discectomy, and we got the microdiscectomy. Okay, the approaches and ways that we can manipulate and access the spine continue to evolve. Looking at the early attempts at lateral approaches, we had the first costotransversectomy by Victor Auguste Menard. I skipped over Percival Pott, just in the interest of time and coherence, but of course Percival Pott gave his name to Pott's disease, tuberculosis of the spine, and this actually kind of, the want to treat Pott's disease kind of drove a lot of spine innovation over the centuries, and this is no exception. So laminectomy was good and people were using it, but they found that they weren't able to drain paraspinal abscesses adequately. So Dr. Menard conceived an alternative approach where he came in laterally, and it's basically identical to the costotransversectomies of today. Unfortunately, this is before we had anti-tubercle medications and people still passed away of secondary infection and draining sinus tracts. But it was an important step forward in terms of our innovation. And this was his, so he did the costotransversectomy, and then about 30 years later, an English surgeon named Norman Kapner adapts it and develops what he called a lateral radicotomy, just to differentiate it and have his own name in the literature, which was further lateral and gave a more ventral trajectory to the spine. But he would divide the erector spinae muscles in a transverse incision, reflect them superiorly and inferiorly, and that would give him his corridor. You're looking at it like, why would someone do that? Well, this guy thought the same thing. So Stanford Larson came around a few decades later, and he credits Kapner in his seminal paper, and he divided the muscles longitudinally as opposed to transversely. He would first reflect the muscles medially, get down, then reflect them laterally, continue, adjust his trajectory, and continue his path towards the spine, and found success with this approach. And this lays the foundation of our modern lateral extracavitary approaches. Those are our approaches to the spine. Those are our decompressions. The path and story of fusion is a whole saga of its own. You could do another grand rounds on this, but it starts with wiring techniques by Berthold Hadra in Austin, Texas. And again, it was first used in Pott's disease. The idea was interesting, but the rigidity was a little bit lacking. Fritz Lange came by a few years later, and he thought that the wiring wasn't strong enough, so he used tin-plated steel rods and he stitched them to the spine through that still the interspinous ligament, and then performed plaster casting. It should be said that with all these early attempts at fusion, until we get into the segmental fixation and pedicle screw fixation, all these early attempts, they tried to fix the spine, but they all required plaster casting afterwards because the rigidity was just not there. Then we have two gentlemen who in the books are described with, or credited with achieving the first fusion. One of them is Russell Hibbs. For my orthopedic colleagues, correct me if I'm wrong, but at least in the literature they describe him as another father, this one of modern orthopedics. And he would take the spinous processes, fracture them, and then place them laterally and between adjacent vertebrae like we do today with locally harvested autograft to create continuous bony bridge. And then he would sew the periosteum back over with suchromic gut. And he got pretty good results, and this was his first case of first series of 3 successful cases. Fusion was assessed with radiographs at the time. The same year, another New York orthopedic surgeon, Fred Albee, also did a similar thing. He took the spinous processes and cut them down the middle longitudinally and then splayed them green stick style, and he also included a tibial autograft. Both worked. That was 1911. Moving forward 30 years, we start saying, okay, maybe wiring isn't sufficient. Maybe these manipulations of bone fractures aren't sufficient. What can we do else? So Don King, a Stanford orthopedic surgeon, comes up with what I believe is the first screw. Don't crucify me if I'm wrong. And he stuck it through the facet. Now, he described in his series 90% solid fusion. You can see his radiographs or his röntgenograms in his original paper, and I must admit it humbles me when I complain about modern day radiographs to see how he studied those things and found bone bridging. But you can kind of see it, and he does describe doing flexion extension views actually as early as 1947 if there was any question. And he saw a 90% fusion rate. But outside of his series, there were many failures. And so people searched for a more rigid solution. And then people talk about Roy Camille getting the first pedicle screw. There may have been, depending on how you define it, one person before him, this gentleman, H. Boucher, working out of Vancouver, Canada. He took King's facet screw and just drove it deeper and a little lateral and inferiorly to grab the pedicle. In this bottom left picture, we can see it just getting into the pedicle a little bit. And then in the top right picture, we can see it going all the way through the pedicle. This was his answer for a more robust anchor, and he just considered the pedicle the strongest part of the vertebral body, though not explicitly in those words yet, and thought that might make a more robust anchor for his screw instrumentation. Yeah, exactly. Yeah. The herald of modern cortical trajectory. Modern cortical screws. We got up another father. The story of fathers. And so, credit does go where credit is due. Roy Camille kind of looked at what basically becomes today's modern pedicle screw. You recognize it was a presentation, I think it was American Academy of Orthopedic Surgeons. He described that he had a talk labeled "The Secret in Spine Surgery," the pedicle. It was
French.
Oh, French. Yes, of course. My apologies. Of course, Roy Camille. He's a French surgeon, and he's known to us perhaps today more for the classical trajectory for lateral mass screws, but he did give us the pedicle screw as well. Okay, in 1933 now, those are our screws. Now, as we all know, you can fuse the spine through more than just screws. So in terms of inner bodies, in 1933, Kapner, the same Norman Kapner who did the lateral dichotomy earlier, conceived of how can we treat spondylolisthesis, and is there another way that we can apply the grafts? And he reviewed anatomy and radiographs, and this was just a hypothetical drawing where he described a graft clearly going from one vertebral body to the next from a ventral approach. However, he described that the technical difficulties of such procedure would preclude attempting this. In the same year, however, a gentleman named British Burns, British orthopedist, performed successfully the first A-lift in a young boy with spondylolisthesis. He harvested a tibial plug and drilled a hole from L5 and passed it through the 5 into the interspace into S1, and the patient had a successful outcome, published in Lancet in 1933. So that's the A-lift. That's kind of the first instance of, what can we do with the disc space in terms of achieving fusion? This might be my favorite story in the whole talk. So this is an orthopedic surgeon in Spokane, Washington, named George William Bagby. And there are these veterinarians at the time in the 80s who are taking care of a very famous steed called, nicknamed the Seattle Slew. And he has succumbed to something called wobbler syndrome. Now, if you look into wobbler syndrome, it's this well-known equine pathology where the horses can't walk. But if you look into the descriptions of it, it's basically ataxia. The horses have myelopathy. It's just cervical myelopathy. And so they say, can you develop a way, but the horse needs to move their neck, and you can't tell the horse to wear a collar. So they're thinking, can you come up with something that can hold these bone fragments together so that we can get a good fusion? I don't know if they said the fusion, but that was kind of the idea. And so this gentleman comes along and he takes a cylindrical cage, cuts it and fenestrates it, and sticks the bone chips in there. And it's called the Bagby Bone Basket, or the Seattle Slew Basket, after the horse that it was first used in. That's an intra-op picture, I think. And that's an intro, but that is a post-op radiograph for the horse. And it works. The Seattle Slew goes on to sire many a sigil after that. And did this on a few horses, and they all did well. He then partners with a guy named Stanley Kuselich to create the BAK, Bagby and Kuselich cage, and that's the first interbody cage used in a human. He presents this in 1984 at NASS, and then they do the cage a few years later, I think by 93 or something like that, 1989, and that's the advent of modern day interbody cages, and that's where we get the word cage from. It was a literal cage. All right, now we get some real heavy hitters that are well known to us on this call. We get Paul Harrington, and now the modern era. If my previous photographs were the pre-modern era, or the early modern era, this is the modern era. It starts with Paul Harrington, the father of modern spinal stabilization. Dr. Abarania knows this story most people on this call probably know this story far better than me, but for what it's worth, he was grappling with the limitations of bracing in idiopathic scoliosis and the polio epidemic that was also going on at the same time, and he saw a need for more rigid fixation that was load bearing as opposed to these screw constructs of the days past. And he, of course, gave us the Harrington rod, a stainless steel rod with originally distraction hooks, but also compression hooks and a ratchet. It's reported to be used in 1 million patients since then, and he achieved good corrections, but as far as I can tell, they did not last. And in studying his own work, he conceived of this, quote, race between instrumentation failure and the acquisition of spinal fusion. He gave us this concept that the instrumentation is there only to hold the body in place until adequate healing or fusion can be achieved, which is why we can take PERC spheres out today if a patient desires it. And his work was built upon John Moe and others in the many years to come, including this gentleman, Eduardo Luque, an orthopedic surgeon in Mexico City. He, like many others, recognized the challenges of the flat rod of Harrington's construct that only had proximal and distal fixation, and he conceived of a notion of well, I don't know if he conceived of it in isolation, but he delivered us a product that gave us the qualities of being contoured and employing segmental fixation. He did it with wires. But this allowed him to evenly distribute the load across the construct and reduce the risk of implant failure, and he gave us the so-called Luque rods that we know. Now we're moving forward. The pedicle screw has come out. We've got now contoured rods, and we've got segmental fixation. And two parties kind of combine these concepts together around the same time. In the Americas, we have Art Steffee with segmental pedicle screw fixation. In his original system, he used contoured plating systems. And this was, of course, seminal work, and he is well known today as being one of the key figures in this story. And at the same time, Cottrell and Dubousset came out with their instrumentation, which also applied the concepts of integrated fixation. It was also contoured, but they used rods. And this really allowed for three-dimensional correction of the spine with derotation, flexion, and extension because it was so rigid. Thank you. I know that was a lot. We went from India to the modern day, and that was the spines of the past. And that brings us to the spines of the present and the instrumentation that we all know and love. I won't belabor this point. Everyone on this call knows this better than me, but modern instrumentation is legion and plentiful and abundant, and I feel like it grows by the minute. But in this world where we have all this history known to us and all this great foundation laid for us, innovation continues. These are just a few wonderful examples. Of course, magnetically controlled growing rods, total disc arthroplasty has caught on, especially in the cervical spine, less so in the lumbar spine. Robotics and navigation, you can't go to a conference without hearing this mentioned every 5 minutes. 3D C-arm is now on the scene. Surface navigation is making a play. And even non-operative management continues to advance with advances in our understanding of functional anatomy and the relevance of the multifidus muscle and how a multifidus strengthening protocol can be useful. And people are even trying multifidus stimulation now with early results that are quite promising. Research evolves. It's left the domain of purely the universities, and we have two at least large innovations that have happened in the last few decades with national and multi-center databases with the advent of modern computing. These are just a couple of registries in the world of spine after NISQIP and other large multidisciplinary groups did them with great success. And we've got the advent and proliferation of the study groups, especially in spine, more than I've seen in other places. They're just wonderful. They really defined how you can be very productive and effective and efficient by tasking a thought leader with a specific topic and then building numbers through high impact surgeons in the field and getting together and collaborating. It's really a wonderful thing and a wonderful time to be alive in academic spine surgery. Meanwhile, the spine itself, it's been static since early antiquity, but our understanding of it has grown. Deformity has expanded. This is not your old Hippocrates scoliosis anymore. The scoliosis has many, many different shapes and sizes, and our understanding of it only continues to grow, and so does the number of books that I'm supposed to read. Now looking ahead at spines of the future. Few disclaimers or pertinent disclosures. I have not studied with any of the occult. I have not taken any formal education in peering into the future, so this will be an amateur's best attempt at looking at what's exciting and coming down the road. You can't talk about the future without talking about robots and nav. Now at these conferences, you hear it being described as enabling technologies. The idea there being that it's not necessarily something that's going to make the best in our field much better. We're not going to make Michael Jordan shoot 64 instead of 63, but we might improve consistency and reduce variability in the interest of better and higher quality patient care across the board. We're using it today for a lot of the obvious things: pedicle screw placement accuracy, reducing radiation exposure, and enhancing our ability to plan preoperatively and execute intraoperatively. In the future, looking at the second point first, AI is kind of the undercurrent of a lot of what's going to come down the pipeline, I think. Artificial intelligence and machine learning and deep learning and neural networks, I think, will enhance every step of the care delivery model, and robotics and navigation are no exception. It's already being done with some of these systems that are learning how much you get out of your PSO or how the spine might react. That'll be interesting after the fusion is done. And something that also might come up, and I've seen a little bit of, is pressure-sensitive instruments to assess the decompression, reduction, or section, so that if you're getting close to the dura, the thing stops. I think that's a step forward towards truly robotic surgery as opposed to what we call robotic surgery today, which is just an arm that helps us place a screw. Personalized implants are on the rise. Patient-specific rods based on preoperative imaging and deformity software are now becoming popular. There's some barriers in terms of cost and other logistics, but they have caught the attention of the deformity community. Patient-specific interbody cages have now appeared on the scene as well, and it's yet to be proven whether those will stand the test of time, but there's a lot of exciting promise there. In the future, we might see different things. Implants informed by AI-enabled plans. We're already seeing that to some extent, but I believe it'll grow and improve incrementally. And then this is just something I dreamed up that, we always look at bone density and we get very careful about Hounsfield units and DEXA scans, and that kind of informs what metal we might use in some cases. But we might come to a world where we actually are able to 3D print patient-specific alloys with different blends of metal to perfectly match the patient's biology and provide the best chance for fusion and the lowest chance for implant failure. This is perhaps my favorite of the futuristic things. I'm going to call it functional deformity measurements. But basically, the concept is that today we look at the spine when we do our deformity planning in static 2 dimensions. And there's been a lot of wonderful work in that area, of course, with all of our classification systems and our key spinal pelvic parameters that we use day in and day out, and new ones keep coming out with better and better accuracy. But in the future, I bet that we will start to analyze the spine not in static 2 dimensions, but in dynamic 3 dimensions. I think there are already some exciting work being done using accelerometers where they put them on the arms and legs and the body and see how the patient moves, and then study people with deformity to see how they behave in their day-to-day lives, not just in an EOS machine. I think that'll be really exciting. I think as that develops and becomes more robust, I think it will birth an entire new generation of parameters to meet, but luckily we'll have AI and computers to help us interpret them and implement them in our preoperative planning software, so that the slide decks I make before our deformities, which currently take me half an hour to an hour, don't take me 5 to 10 hours. It's also hard not to mention endoscopic surgery. I think it's just exciting because if you look at it from the patient's standpoint, what's the ideal, right? The ideal, if I'm a patient, is that I have a problem. Well, I don't have a problem, but if I have a problem, that someone waves a magic wand, my problem goes away. And if we look at surgery as the magic wand, on one end of the spectrum, we have the old school 10-inch incision for a 1-level case. And on the other end of the spectrum, in today's world at least, we have endoscopic surgery with centimeter large incisions, through which we have now successfully done discectomies, T-lifts, but it's being done at relatively few locations. It is exciting, but there's some questions about long-term durability and efficacy. But I do believe that this technology will spread, and I believe the indications will grow as we become more facile with it. My friends, that concludes our tour of the past, the present, and the future. And it's been really humbling and frankly fun and exciting to read through all of this and reflecting on where we've come from and where we are and where we're going. I feel that the past is very rich. There's just so much value there. There's so much wisdom there, and it's worth diving into it. I know I'm supposed to be reading Benzel and DeWalt and all these things, and I am, but reading the history is fun. It gives us a perspective that should not be lost. And it informs my understanding of today, which is that the present is abundant. There's technology everywhere, there's research everywhere, and there's thoughts everywhere. Everyone's getting in on the spine game. And because of that, it makes me think that our future is very bright. And I'm very excited about being a trainee entering this field. I'm very excited for the patients who I will be fortunate enough to help treat in the future. And I just think we've got a great road ahead of us. And with that, thanks for having me here. It's been a wonderful 6 months. I really appreciate everyone welcoming me to this family. And shout out to Camille and Amber, the absolute best 2 fellows that anyone could have ever hoped for. Cheers, guys. And on that note, happy holidays, and I'll take any questions.
Awesome. Dr. A, you still on?
Jay, I think we need to nominate you as the new SRS historian.
I do have the amount of nerddom in me for such a role, but yeah, it's just fun. Anytime you get on, you go to a conference and you see somebody saying, "Hey, I'm going to give a talk about history," I feel like you can hear the groan in the audience. It's just like everyone's like, "Oh," and half the room automatically falls asleep, and everyone's like, "Again, history," but it's exciting. It's interesting. I think understanding who the people were helps us remember what they did a little bit more as well. It's not just bullet points in a textbook. It's flavor, it's color, and we're dedicating our lives to this kind of stuff. It might as well be fun. So part of the thought there.
Yeah, you would have loved this. I was at a meeting a few years ago, and somebody gave this historic talk on cranial remodeling. and how
Mhm.
various cultures have done it for fashion over the years, all the ancient civilizations. It was really amazing. And this guy was like from some random practice in like Binghamton, New York, but it was a phenomenal talk.
Yeah, he and I would get along. That sounds fun.
Thank
Putting
you very much.
respect.
Jay, that was a great talk. And,
Thank you, sir.
I think one of the things that you mentioned is, the difficulties that people went through to achieve what they achieved. And also, it's not just the surgical technique, but all other things that help the spine surgeons to do what they can do today. For instance, the MRI, anesthesia, and other things. So it's kind of a teamwork with other specialties, which I think we should not forget, and be, collaborative with, keep an eyes open beyond the spine and see what we can get and bring it to the spine world. So it's a great talk. I know that we need people like you in our historical committee of the SRS. So when you apply, uh, I would nominate you to that committee. so that's true. That's true. One thing I just wanted to mention that about lordosis and the Luque and Mo, I think the Harrington rod was really the first who recognized the flat back, and he sort of contoured the Harrington rod and used that square end hook that would not rotate.
I see.
And so I think Luque sort of did that because of segmental fixation, but Mo was the first one. But it was a great talk. Thank you.
Thank you. I'll add a slide on that next time. Appreciate it.
I'll send it to you.
Thanks for the nomination. That would be an honor.
Thanks, guys. It's a little over, but Jay, appreciate you. It's been an awesome 6 months.
Thanks.